So good evening, dear friends. And we started on the warm afternoon of a Sunday, and we are here now towards the end of this wonderful webinar. And without wasting much time, we are running a little late. And Doctor's wonderful presentation by Dr. Jagnany, short and sweet, but mine is A to Z of insulin. So I think this will not be so small. So, but I'll try to make it. So let me begin. What is insulin? The first and the foremost, I think we have forgotten the definition. It was discovered in 1921 by Banting and Best, of course. It is a 2-chain polypeptide with 51 amino acids, and it may be human, porcine, bovine, or analog. So porcine and bovine, I haven't seen in my life. It was, as far as I remember, we have only used human and analogs. This is the insulin structure, not going into detail. However, the 2 disulfide bridges, I mean, this is where the changes take place in the analogs also. And here is the photo of these 2 Mahapurusha, I would like to say, and of course, Marjorie, the dog whom they tried on the effect of insulin. So different sources, insulin, the differences are based on the source. Porcine and bovine insulins, they're very inexpensive. I don't think they're used anywhere now. Human insulins are very commonly used, and analogs are definitely, sometimes they are superior, but sometimes it's the older human insulin which act. However, the chart goes as analogs, human, porcine, and bovine insulins. Analog insulins have greater stability and consistency as compared to the other insulins. Now, preparations, we have different types of preparations of insulin. One is the rapid-acting insulin analog, the short-acting, the regular insulin, which is also known as the soluble insulin. You can see here the time of onset, the peak, the duration of these insulins. Rapid-acting starts acting within 5 to 15 minutes, peak is somewhere 30 to 60, and duration is 2 to 5 hours. And similarly, we have the intermediate to long-acting insulin and the long-acting insulin analog we have. And here, the long-acting insulin analogs, the time can go for more than 24 hours. We have wonderful insulins nowadays, and we have a plethora of them to choose. And they're suited for different types of patients we have in our clinics. However, in hospitals, most commonly used is the rapid-acting analog and the short-acting regular insulin. Of course, the long-acting insulin glargine is also used. Now, this is the evolution of the basal insulin. We are talking the one of the best insulins to begin with. As we'll be seeing the guidelines, they say, this is not my point of view. The guidelines, they recommend the basal. So this was how it was developed long back in 1946. NPH was developed, then came glargine in 1992, the 100 glargine 100, then Detemer, and then Degludeg, and then of course glargine 300, which is being so widely talked about nowadays. And this is the relative peak of each of the insulins. We are getting the more flat peaks with more advanced insulin. So this was what is insulin, and the points to remember. One of the major points to remember before giving insulin are where to give insulin, when to give insulin, and who can give insulin and who should take insulin. So when we are preparing for an injection, first is choose a spot. So spot should be certain, we have certain sites where insulin should be taken, and the spot on the skin should be easy to reach. That is the best. It is not easy to take on the buttocks, so easier to take on the thighs or the abdomen, but self-injection on the arm, taking on the arm, upper arm, is also very difficult. And of course, hygiene is always there. Hands should be thoroughly washed, and the area to be taken should also be clean. Now, this is very, very important, and I think this is very difficult for us to explain to each and every of our patients. We definitely need a counselor who can explain all this, what is the correct method. And you can see here the skin fold for subcutaneous injection. These are the wrong methods, the first, the second, and the last one. What is correct is the third, that is the correctly lifted skin fold. And here the insulin, the injection should be there so that it does not go very deep within. Now, when we inject, the angle formed between the needle and the skin should be 90 degrees. What I generally tell my patients, what my teacher taught me was, think you're stabbing someone ruthlessly, just stab. So this is how we don't stab it nicely at an inclined angle. We do it at a 90 degrees. So it should be, we should hold the syringe like a pen or a pencil and insert into the needle in one go. It should not be wiggled inside with fear that I'm pricking myself. It should go in one go at a 90-degree angle. And this is the correct way of how to take insulin. So once this is, I mean, if I go into the detail, I think I'll be taking another half an hour or so. So the best way is to pinch, and then first we have dialed and pinched, and then take the insulin and then press if it is a pen, and then the plunger should be pressed, and then the pinch should be released and the pen should be taken out. I mean, 10 seconds holding things should be also be there. So this is how the correct thing should be taught to the patient. One of the major flaws we see in our practice, why the same insulin does not work if the patient is not taking correctly. As Dr. Ajay said, we see patients taking in the calf, we see patient taking in the lower arm also, full of black spots. So these are the wrong sites. The needle, how it should be pulled out, it should be pulled out in one go after counting 10. And for a pain-free, nearly, I would say this, not pain-free, nothing is pain-free. So nearly pain-free insulin, a new needle should be used. Patient muscles should be relaxed. That is, the patient should be very, very comfortable. What I said just previously, always use a new needle. That is just theoretical, I would say, and using a new needle every time is not very practical in India, considering the financial constraints. So these are some small things. It can be used, a syringe can be used, say, up to 4 times, or the needle of the pen can be used up to, say, 5 times, depending on the site, depending on site of the insulin injection site, the thickness of the skin, and if the needle is damaged once the patient was trying to cap it, and so many factors are also there. So this is the beautiful picture which shows the reused needles, how it gets damaged, and this is what the one which is going to cause pain to the patient, can cause infection to the patient. And of course, one very important thing which I recently came around for 2 patients, that injections should not be given through clothing. They were taking in the upper arm, wearing full sleeve shirts, and they're taking here. So that was one very important thing, the first 2 patients that came to my clinic. Now, this is again very important in special situations. Say if the patient is very, very thin built and a wasted individual, a 4 millimeters needle with a pen device should be used. And then, of course, a combination of raised skin fold and angled insertion so that the pen goes deep inside, the pen goes to the correct site. And in the patient is obese, a slightly longer needle, 4 to 6 millimeter needle, and lifting the skin fold is not very, very necessary here. So these are some very small things which we should teach our counselors, our dietitians, our diabetic educators, so that they can pass it on to the patients. Or if we do not have one, we can just display it in our clinics through television, because visual media has a better effect. Now, insulin delivery mode, syringes are the most commonly, and they're one of the most dangerous things, because we have 2 types of insulins, that is the U100 and the U40, and the most recent, the U100, the U300. However, there's a lot of confusion, people. This is the difference. You can see here the U40, the markings are slightly away from each other. The syringe has a red cap, and here it has an orange cap. And the most common mistake we see in our clinics is patient taking U100 insulin with a U40 syringe. So if we correct at this point, whatever the prescription the patient is following starts working once again, and the patient is again, it's just a small thing which the patient never paid. The patient didn't know. It was actually the pharmacist who was at a fault. And here, whenever we write, if the patient is taking U100 insulin, we should mention in our prescriptions that this should be taken with a U100 syringe, and it should be underlined with a red pen. Then, of course, the other device which we have is the pen, the one very commonly used in our clinics. It is very convenient to use, easy to carry. We have the disposable pens, we have the refilling pens. They are very easy, they are very convenient to use. However, in India, cost, again, as I say, is nice as a pocket, it should be pocket friendly. It is a little costly, but not actually very costly, because number of syringes to be changed, unless the number of needles to be changed goes on to a slightly 5 days. So it is a slightly less more expensive. And then of course, some insulins which we use do not come in the form of cartridges. Again, this is the insulin pump, which is also widely used nowadays in the affluent class. It gives a wonderful glycemic control. However, it is the pros here: less jabs, takes insulin as and when needed. We get less of fluctuations. However, it is a little difficult to use because it is very, very costly. And of course, if the tubing, there's the block in the tubing, it can lead to a stop in the insulin flow to the person, and then it can cause the risk of diabetic ketoacidosis. Diabetic skin infections can occur also. So everything has a good and a bad aspect, and this is the bad aspect. Now, this is what I was saying, the rotation of the sites. It can be taken in the abdomen, it can be taken in the thigh, it can be taken in the upper arm. However, every time when a person takes insulin injection, the site should be rotated as it is seen here. Even in this abdomen, an imaginary clock should be made, and the patient, once it takes 3 p.m., the next should be at 4, 5, 6, and so on. It should keep on rotating, because if it is not rotated, what can happen? We all know hypertrophy and scarring, and also lipodystrophy can occur. Now, when we talk about, when we tell our patients, these are the drugs to be taken, fine, the patient is happy. They keep on adding drugs, though the lifestyle maintenance will be absurd. However, the moment you talk about insulin, you're going to talk about insulin and say, nahi, doctor sahab, I won't be able to take that. That is, I cannot inject myself. So this is commonly known as insulin distress. And I can very well understand the mental trauma which the patient is undergoing at that time. So first, we have to converse with the patient about the insulin, that this is something it's a life-saving thing. I mean, it's one of the best drugs which we have. The best way of treatment we have, it is just like a drug. This is it. So these all things should be instilled into the mind of diabetic patients every time they come to a clinic. And then, of course, why insulin is necessary, the loss of beta cells and all. If the patient is slightly educated, they all tend to understand. And of course, there is this Google who's going to help us a lot. And then, of course, the problem solving patient should be discussed. There's so many problems associated with insulin, how to store the insulin, how to carry the insulin. There's so many things. And decision, and I always say that if the patient's attendant is ready to take and you are ready to give, it is never going to work. I wait for the patient to nod with a smile whenever I say, I want to give insulin now. So it is the patient. This is a shared decision making between the patient and myself. So we have to agree to one point, and somehow this makes the insulin work. Of course, expectations should be very, very clearly explained, that this is the time, this is how we slowly titrate the insulin. And it's not that you take insulin now and the blood sugars are going to come down, tuck, 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 in another 4 or 5 days. So the reality should be explained. The management, the efficacy in management, the barriers, what we generally face, first is the prick. Yes, the prick will be there, but with the most modern methods, it is nearly painless, I would say. Hypoglycemia, weight gain, these are all which we fear. And another which we fear, however, the patient does not know, is the fluctuations in the blood sugars due to the insulin injections. However, now we have good insulins. We have basal insulins, which do not cause hypoglycemias. And of course, they give even the second generation insulins, which have a very flat profile, and the fluctuations are very, very less. Of course, the convenience and lifestyle, yes, there is a little bit of adjustment. Adjustment is always there. The compromise, without compromise, we all fail. Multiple insulin dosing, the patient said, every time I have to take food, every time I have to take injection. But it has to be explained that if you start the correct time, whenever we are saying, it is only one type of insulin which you can take with the major meal of your day. We have good insulins, we have combination of insulins, which can be taken with the major meal of the day, and you can get good control. Erratic lifestyle, some of these ministers, these executives, they do not have any time, they do not have any sleeping time, they do not have any eating time. So we have insulins which work very well, once weekly insulins. So many insulins we have. Now, who For who should we initiate insulin? Yes, of course, type 1, no doubt. The second is, are those type 2 patients who are uncontrolled on OADs, at least 3 OADs. Now, basal, as I was talking about, this is one of the most accepted insulin, as the guidelines say, that because it is easy to initiate. Why is it easy to initiate? It is easy because it is to be taken once daily. Once daily, we have different insulins. Yes, of course, it can be also initiated. However, once daily at a fixed time, not related to food, with a minimal pain, not causing hypoglycemia and less of weight gain, is why this should be one of the most preferred insulins should be started. We have these premix and we have these analogs which can be started. That depends, actually, this is not a set rule. These are the guidelines. It actually depends on the clinical acumen of the patient. What insulin should be started. The multifaceted benefits of timely initiation of insulin therapy. First and all, what we aim is preserves the beta cell mass and function, prevents the glucotoxic effects of hyperglycemia. It protects against endothelial dysfunction, causes vascular damage, and of course it alters the course of the disease progression in a positive manner, and also it tends to increase the insulin sensitivity. So we have a number of good points towards insulin initiation. Now, once insulin is initiated, then of course we need the titration, and then we need the intensification, also the management. Actually, it is initiation, titration, and then the maintenance, and then comes, once it is uncontrolled, is the basal insulin is there, and then the prandial has to be added for intensification, so that we get a better postprandial. Now, here is when prandial should be added. When the basal is good, but there are prandial peaks which are uncovered. So the peak which is the highest, before that, when prandial insulin can be added, or we have insulins which have a combination of the basal and the prandial, and that can also be used. So these are the intensificators. The advantages of basal prandial intensification is there is a decrease in the PPG excursions. Dose titration of both basal and prandial insulins can be taken care of individually. Of course, hypoglycemic incidence is decreased, because in going on increasing the basal can lead to a morning hypoglycemia, and of course the patient gets a better glycemic control. Now, this is something very, very important. We all know the legacy effect, that the very early, this is the red is the conventional and the blue is the metformin patients who were on metformin. This was taken from the UKPDS, and to seen that those patients who had a better glycemic control initially definitely had a decrease. See the massive decrease in microvascular complications, 24%, 15% in MI, and 13% in all-cause mortality later in life, from 1998 to 2008. So the initial strict diabetic control is going to show its effect later in life, and this can be explained. I have a graph of this in my clinic which I show to my patients and many of my educated patients. This graph makes it easy to explain to them how initially not only diet is going to work, but it is the medicines which are going to help you later in life. This is the ADA recommendation for titration. We all know we can start with 0.2, 1.1 to 0.2 units per day, approximately 10 to 16 units per day of basal, and then slowly it can be intensified. This is something very interesting, how we can increase the dose of insulin. SMBG is of course a must, but the patient should not be troubled to prick his fingers thrice or 4 times daily. If the patient is started on basal, it should be very, very slow. So these are some of the very common questions about insulin. What dose to initiate basal insulin? 0.1 to 0.2 units per kg body weight per day. When should we start talking about insulin? At the very day the patient gets the first uncontrolled blood sugars. Okay, insulin can also be a part of your treatment later on. When should we start talking about titration? Whenever we initiate insulin. When is the request for the first follow-up? Within first to 2 weeks. Fasting plasma glucose is the basic parameter which is to be monitored for the maintenance, for the dose titration. Then of course, before starting insulin, we always talk about hypoglycemia. What are the symptoms of hypoglycemia and what is the treatment of hypoglycemia? That is something very, very important. Now, this is something other than our medical aspects. It's about about the insulin storage, that this should be very well explained to our patients, how to store, where in the refrigerator should be stored. Once unused insulin cartridges should be kept in the door of the refrigerator. Before taking insulin, it should come to the room temperature. Once the cartridges have been opened, it can be kept outside at room temperature. It's 15 to 30 and not 45 as we see in India. And then, of course, recently I have started telling my patients what not to do also. That is also very important. Do not freeze the insulin. Do not use the insulin after the expiry date also. This should also be mentioned because many of our patients do not know. And also do not expose the insulin to direct sunlight or light. Now, when traveling with insulin, this is something very, very important, very commonly used. With now the air travel becoming so very common, the patient should be explained that we should keep the insulin with the baggage and not in the check-in, because the temperature control is not there. Of course, we should carry some sweeteners with us. The prescription should be carried with you, and of course the diabetic identification card should also be there. And the insulin storage, as I was telling you, how it can be stored in refrigerators. But remember, so many of our patients do not have refrigerators. So where do they keep? Very simple. What we get, earthen pots, chai ka कपटी जिसको हम लोग झारखंड में बोलते हैं, कप बोलते हैं, या पूजा का कलश होता है, that is छोटा सा घड़ा होता है, or the pitcher small, water can be kept there, the vial can be kept into it. Water should be there up to the neck of the vial. And of course, if the patient does not have also that also water dipped cloth bag should be can be taken, and they work very well with those patients who do not have refrigerators at home. Now, this is the picture I was thinking of showing to you. Hypertrophy, lipohypertrophy. We can see here the insulin, if it is inserted again and again, they're taken again and again, it does not seem to work. It gets black. And this is lipoatrophy also, that is wasting of subcutaneous tissue. So the points to be remembered after giving insulin. See, we've talked about how to keep insulin, how to give insulin, how to titrate the insulin. After giving insulin, what are the main points? The needle should always be turned, should be broken and then discarded, so that if it is thrown into the garbage, the animals there or the rag pickers, they should not damage their hands. After giving insulin, the pen should be held for 5 to 10 seconds. Insulin, the storage should be proper. Even after taking insulin, the needle should be capped. We often see patients not capping the needles. And of course, do not skip the meal after taking insulin. And this I always emphasize to my patients several times after I initiate insulin. Mistakes to be avoided while giving insulin, of course, correct dose of the insulin, storage of the insulin, rotations of the insulin, titration, SMBG. If the dose is, sometimes this is very important, if the dose is mixed, never take double dose, which can lead to hypoglycemia. And if the patient is taking two types of regular insulin and basal insulin or an NPH, and the same type of pen is there, and the patient by mistake tends the regular insulin and the double dose in the night, the patient will definitely go into hypoglycemia. So some mark should be there on the pen so as to differentiate the two types of pen. So these are some very, very important things. I mean, talk about insulin can be endless, my dear friends. So, but I think we are running late, and I have tried to hurry up through A to Z and coming to the Z of my talk. Thank you all for your patient listening. Thank you